Hey guys, welcome back to my channel, The ENT Resident. Today we'll be having a discussion on tuning fork tests. Now, these are some very important clinical tests that you should know in your clinical practice. When you're seeing a patient, we usually try to determine certain findings about the kind of hearing loss the patient might be having by performing these tests. You can also now purchase my notes. I have added links in the description. So, in today's discussion, we'll be talking about 6 tuning fork tests. But before we go into them, let's first try to understand what is the basic principle that we are using to test these tuning fork tests. So, first of all, is we use tuning forks of different frequencies. There's a lot of frequencies of tuning forks that are available, like 128, 256, 512 hertz, 1024 hertz, 2048 hertz, and 4096 hertz. But out of this, these are all not used practically in routine life. The ones that are used more commonly are 256 hertz, 512 hertz, and 1024 hertz. And even amongst this, if you had to choose one tuning fork, and if you had maybe option of choosing one of them, what would you choose? You would be choosing the 512 Hz. Why is this the most preferred tuning fork amongst these three? That is because this frequency lies right in our speech frequencies. Secondly, with this frequency, it also produces less of overtones and the tone decay is very less. That is why we'll perform 512 Hz over the other two tuning forks. Now, another MCQ question over here would be, what is the normal speech frequency? And that is 20 hertz to 20,000 hertz. So this is a very important MCQ question. Now you have a tuning fork. How do you activate the tuning fork? How do you get it vibrating? We'll vibrate it by either striking against the examiner's elbow or the heel of the hand. You should never strike it on a hard surface. So that is how we vibrate the tuning fork. Next, let's try to understand what are the two things that we test using a tuning fork. One is air conduction and second is bone conduction. Now let's look into each one of them. So in terms of air conduction, how do we test it? We'll take the vibrating tuning fork and we'll place it vertically in line with the external auditory canal. Let's look at the image over here. This is the external auditory canal. We'll place it vertically in parallel to this external auditory canal at a distance of about 2 centimeter from the opening of the external auditory canal. What is the pathway that this sound that we are making is taking? Let's look at the second image over here. So the sound will take this pathway. It has entered to the external auditory canal. Then it goes via the tympanic membrane, then via the ossicles on the middle ear, and then it reaches the cochlea. And from the cochlea, it goes via the auditory nerve to the central auditory pathway. So, this is the whole route through which the air conduction is taken in. So, as you can see over here, so therefore, air conduction is testing not only our conductive pathway, it is also testing our sensory neural pathway, because the conductive pathway is this first part, the external auditory canal to tympanic membrane through ossicles. This is our conductive pathway, whereas from cochlea onwards, this becomes our sensory neural pathway. So, air conduction testing is basically a test for both conductive as well as sensory neural pathway. This point is very important for us to remember. And normally, when we test air conduction and bone conduction, this air conduction will always be louder and longer than the bone conduction. Now let's look at bone conduction. How do we test this and what are we exactly checking over here? So this image over here shows how to perform bone conduction. So you vibrate the tuning fork and then place the footplate of the tuning fork on the mastoid process of the patient firmly. Now, what bone conduction does is it is directly. Let's look at the second image over here. This is our bone conduction. We have placed it on the mastoid process. This directly stimulates the cochlea instead of going through the pathway that we saw for air conduction. So, bone conduction is basically ending up stimulating only the cochlea. And what does the cochlea represent? The cochlea will represent the sensory neural hearing. Therefore, bone conduction is testing only the sensory neural pathway. So, what do we learn over here? Air conduction is testing the conductive pathway as well as the sensory neural pathway, whereas bone conduction is only testing sensory neural pathway. This is most important to remember over here. We'll take this knowledge forward to understand each one of the tuning fork tests that we'll be talking about. Next is we'll also be talking about two types of hearing loss here. One will be conductive hearing loss and one will be sensory neural hearing loss. So as we perform each of the tuning fork tests, our results will be interpreted as either normal or conductive or sensory neural hearing loss. Now what happens in sensory neural hearing loss? If let's look at our image above over here. So this is our conductive pathway, right? So, anything that any blockage in any of these areas will result in a conductive hearing loss. So, say for example, we have wax in the external auditory canal. Now, what will happen? The air conduction sound that was supposed to enter from here, it will reduce because of a blockage in its path. Whereas sound will reach via the if there is any sound which is reaching via the bone conduction, where it bypasses the external as well as the middle ear, in that case that sound will be heard normally. So you see in this image, the bone conduction pathway is going directly to the cochlea. In that case, since it has bypassed this conductive apparatus, in conductive hearing loss the bone conduction will be normal, whereas air conduction will be reduced. So, that is a basic understanding that we need to have. And in sensory neural hearing loss, what will happen is the bone conduction will be reduced because what we learned is bone conduction is testing the sensory neural pathway. So, when the sensory neural pathway is destroyed or damaged, in that case, it will lead to reduction of the bone conduction. So, this is some basic things to remember before we move into discussing each one of the tests. Now, what are the tests that we'll discuss today? So, we'll have 6 tests over here that we'll discuss, out of which 3 of them are more commonly done. So, we have Rinne's test, Weber test, absolute bone conduction test, Schwabach test, Bing's test, and Gelle test. Now, let's dive into each one of them and try to understand what are we doing here, what are we trying to interpret and test over here, and what is our inference. So, first of all, is Rinne's test. Now, Rinne's test, the basic principle, what are we trying to see here is we are trying to compare the air conduction of the ear with the bone conduction of the ear. So, we are doing both of these things in the same patient and we are comparing their air conduction with bone conduction. Now, how will we perform it? So, we'll take a vibrating tuning fork, and as you see in the image over here, first we'll place it in the on the mastoid process. Now, after placing this, we'll ask the patient to indicate us when they stop hearing the sound. Now, as soon as they indicate to you that they have stopped hearing the sound, we'll change that position into this, the second image over here, where we place the tuning fork 2 centimeter parallel to the external auditory canal. And as a result of this is how we are testing the air conduction. And first we tested the bone conduction and next is we're testing the air conduction. Now, if after this, if the patient tells you that they are still able to hear the sound when you placed in front of the external auditory canal, in that case, the air conduction will be more than the bone conduction. This is one way of testing. There's another process which is known as the modified Rinne's test, where the testing is a little different, where instead of asking the intensity, instead of asking the time duration for which they are able to hear the sound, we are asking the patient to compare the loudness of the sound that they are hearing through air conduction and bone conduction. Now let's try to understand what are the possible results and where do we see it. Firstly is we learned that air conduction is more than bone conduction. When this finding is found, This is known as Rinne positive. And what does it indicate? It either indicates a normal person or it will indicate a sensory neural hearing loss. Why so? In sensory neural hearing loss, as we discussed, only the bone conduction is affected, whereas air conduction does not get affected because air conduction involves both the conductive pathway as well as the sensory neural pathway. Therefore, the air conduction will be more than bone conduction. Now, when the bone conduction is more than air conduction, which is the opposite, that is known as Rinne's negative. And this will be found in conductive hearing loss. Now, what is the logic over here? So, if this is the ear canal, this is the middle ear, and this is the cochlea. Now, this part is testing the air conduction, and this is the conductive pathway, this is the conductive pathway, and this is the sensory neural pathway. Now, in case of conductive hearing loss, we'll have blockage over here in some part of the conductive pathway. When that is happening, the air conduction will reduce because the air conduction involves both of these pathways. So, because the air conduction reduced, but the bone conduction remains same because the cochlear function or the sensory neural function over here is normal, we are going to see a bone conduction more than air conduction. Now, there's a small mnemonic that you can remember so as to remember what is the finding you see in Rinne's test to make it easy. So, there are two words that we remember, corn and SERP. So, corn is for conductive hearing loss, we see Rinne's negative, and SERP is sensory neural hearing loss, we are seeing Rinne positive. So, this is a very tiny way to remember what is the interpretation of Rinne's test. Now, other than this, we can also use Rinne to predict the airborne gap even before we have done any audiometric test. So, if the Rinne is negative for just 256 Hz and it is positive for the other two tuning forks, in that case, this will indicate a airborne gap of 20 to 30 decibel. Second, if Rinne is negative for both 256 and 512 Hz, but it is positive for 1024 Hz, this will indicate a airborne gap of 30 to 45 decibel. And lastly, if Rinne is negative for all the three tuning forks that we are using, in that case, it will indicate an airborne gap of about 45 to 60 decibel. So, this is some important things you need to know about Rinne. There's another very typical MCQ question that is asked, and this is what is false negative Rinne? Now, we'll try to understand this. So, in severe unilateral sensory neural hearing loss, we are seeing false negative Rinne. Now, what is false negative Rinne? So, negative Rinne is when the air conduction is lesser than the bone conduction, right? So, in this case, we are seeing that the air conduction is absent, but the patient is able to respond to bone conduction. Doesn't this mean that it should have been a conductive hearing loss? But it's not. Let me try to explain what is happening here. So, in a case of severe unilateral sensory neural hearing loss, let's look at the image over here. This is our external auditory canal, this is our tympanic membrane, and this is our cochlea on one side. Let's imagine this is our cochlea of the other side. Now, we have a sensory neural hearing loss on this side. So, let's say that this cochlea is very badly damaged. So, if this cochlea is damaged, when we are trying to check for air conduction, this is severely damaged. So, when we are trying to check for air conduction, the air conduction will be reduced because the cochlea has been damaged here. Why? Because air conduction is testing both our conductive as well as sensory neural component. So, we'll see a reduction in air conduction. Now, next is bone conduction. Now, when we are trying to do bone conduction directly goes and stimulates the cochlea, right? So, in this case, when the bone conduction is sound is reaching the cochlea, it is not able to stimulate it. So, what is happening here? There is a transcranial transmission of sound happening where it ends up going to stimulate the cochlea of the other side. So, the other side here starts perceiving the sound that we are transmitting by the bone conduction. as a result of which the patient will be able to hear some kind of bone conduction. So, what they'll say is that bone conduction is longer or louder than air conduction. So this is why we get a false test over here, where we see a false negative Rinne in case of severe unilateral sensory neural hearing loss. Now, how do we combat this diagnosis? How do we find the right answer? This diagnosis we can correct it by masking the non-test ear with Baronese noise box before we perform the test. When before we are performing, especially the bone conduction test. And second is Weber will also help us, as it will get lateralized to the better ear in case of in case of sensory neural hearing loss. So this is about false negative Rinne, and this is a very important MCQ question that you get. The simple way to remember this is, in a case of severe unilateral sensory neural hearing loss, the bone conduction is severely damaged, so that leads to reduction on the air conduction. Whereas bone conduction is still heard, that is happening because of transcranial transmission of the sound to the opposite ear. So that's all about the Rinne's test. Next, let's look at our second test, which is the Weber's test. Now, this is also a very important test. What does Weber test do? Weber test works on the principle of sound lateralization through the bone conduction. So, Weber's test is only testing for bone conduction. And what does bone conduction test? It is testing cochlear function. So, therefore, Weber test is a test for cochlear function. And Weber's test will help us in determining the side and the type of hearing loss. What it will not determine is, it will not determine the degree of hearing loss. We'll get an idea about the degree of hearing loss when we perform Rinne's test. So, Weber's test is a test of bone conduction, which means that it is a test of cochlear function, and we determine the type and side of hearing loss over here. How do we perform it? So we'll vibrate the tuning fork, and let's look at the image over here. We'll either place it in the middle of the forehead or the vertex, and then we'll ask the patient, where are they able to hear the sound better? Which ear are they able to hear the sound better? There can only be three interpretations over here. So either the person tells you that they are able to equally hear on both sides. So when you have vibrated the tuning fork and placed in the middle, so we'll have bone conduction going to both the cochlea. In a normal person, both their cochlea are acting normally. So both the cochlea will be able to perceive this sound equally. So in a normal person, we end up having equal amount of sound heard in both ears. Now, if there is a person who has conductive hearing loss, means there is some difficulty in the conductive pathway, they will hear it better in the affected side of the ear. Because what happens in conductive hearing loss is the conduction pathway in this person is blocked. Therefore, any noise coming through the air conduction pathway is blocked. So, on this side, we'll be able to perceive the bone conduction more because all the ambient noise has been cut out. Therefore, in conductive hearing loss, the Weber gets lateralized to the poorer ear. In case of sensory neural hearing loss, the lateralization will happen to the opposite ear. Why will that happen? Say in over here, one second. Let's say in this case, the left ear has sensory neural hearing loss. That means the cochlea is damaged on the left side. So now, when you are placing the tuning fork, it is supposed to be perceived by both the cochlea. But since the damage is in the left side cochlea, so the left cochlea is not able to perceive the sound, only the right cochlea is able to perceive the sound. Therefore, you end up hearing better in the better ear rather than the affected ear. So that is how we determine the site and the type of hearing loss based on Weber's test. Next is Schwabach's test. Now in Schwabach's test, what we are trying to do is, we instead of comparing the patient's ears with each other, we will be comparing the patient with that of examiner, considering that examiner's ear is normal. So what we are comparing is, we'll compare the patient's bone conduction with that of the examiner, assuming that our examiner also has normal hearing. And second is, we'll determine whether this hearing loss is conductive or sensory neural by comparing the duration of the bone conduction. Now, as I've mentioned multiple times so far, what does the bone conduction detect? It reflects the status of the cochlea. Now, let's talk about what will happen when the bone conduction becomes longer or shorter. So, when the bone conducted sound is heard for longer, what it shows is when if there is a conductive hearing loss and the conduction is blocked, in that case, the inner ear will be able to receive the bone conducted sound better and longer due to removal of the masking that is happening by air conduction. So, I've mentioned before that if you end up masking the ear, uh, for the air conduction, the sound will be heard for longer. Whereas the bone conducted sound will be shorter when the cochlea or the nerve gets damaged. That's because the cochlea function is reflected by the bone conduction. Now, let's look at this examination first. So, what we'll do here is we'll take a vibrating tuning fork and we'll place it on the mastoid of the process of the patient. And we'll tell the patient to signal us when he stops hearing the sound. Now, the moment he stops hearing the sound, immediately we'll place the tuning fork on the examiner's mastoid. And then examiner will check whether they are still able to hear the sound or not. Now, we'll compare this duration with that of the patient. So, our interpretation can be three different interpretation. One is normal Schwabach, where both the patient and the examiner are able to hear the tone for the same time. That means patient has normal bone conduction. Second is lengthened Schwabach, which is seen in conductive hearing loss. Here, the patient is able to hear the bone conduction longer than the examiner. What does it mean? So, if the patient has conductive hearing loss, that means there is some kind of blockage in the conductive hearing pathway. So, because there is a blockage in the conductive hearing pathway, it will reduce the external noise that is coming via air conduction to the ear. Now, because it is reducing the external noise, which usually ends up masking the bone conduction, therefore, the removal of this will lead to an increase in the bone conduction of this patient. So, therefore, in a conductive hearing loss, we will see a prolonged Schwabach rather than a reduced one. Now, where do we see a reduced Schwabach? We'll see reduced Schwabach in case of sensory neural hearing loss. What does this mean? Here, when you take the tuning fork from the patient's mastoid and put it on your own mastoid, you will be seeing that you are able to hear the bone conduction still. What does that mean? That means the patient has heard the bone conduction for a shorter duration of time. This means this is a reduced Schwabach. This will indicate a sensory neural damage to the pathway, because only when there is a sensory neural damage to the pathway, the cochlea gets affected, and when the cochlea gets affected, it will directly reduce the bone conduction, because bone conduction is a test for cochlear function. So, a normal Schwabach means the patient is normal. A lengthened Schwabach or a prolonged Schwabach test would mean a conductive hearing loss, and a shortened Schwabach will mean a sensory neural hearing loss. Next is our fourth test, which is absolute bone conduction test. Now, this test is very similar to Schwabach's test. It is actually a modification of Schwabach's test. So, sometimes this is also known as modified Schwabach's test. Here also, we are comparing the patient's bone conduction with that of the examiner, assuming that it is examiner has normal hearing. But second important thing that comes in here, which is not there in Schwabach, is here we are blocking the air conduction by occluding the external auditory canal by pressing the tragus inwards. So, therefore, absolute bone conduction test is actually only testing bone conduction. Whereas in case of Schwabach, we saw that we were not blocking the ear. So, Schwabach was actually ending up testing both air conduction as well as bone conduction, which is why we were being able to tell what is the result for conductive hearing loss. But if we end up blocking the air conduction and only check the bone conduction, that will be a true test of the cochlear function. So, absolute bone conduction is a test where we are checking only bone conduction. So, what will we do? Here, the external auditory canal of both the patient as well as the examiner needs to be occluded. How do you do this? We'll do this by pressing the tragus inwards. What will this do? This will block all the environmental ambient noise to enter via the air conduction route. Now, after that, we place the vibrating tuning fork in the mastoid process of the patient, and then the process is similar where we ask the patient to signal us when he stops hearing the sound, and then immediately we'll place the tuning fork on our own mastoid, and then we'll check whether we are still able to hear the sound or not. Now, what is our interpretation over here? If the patient and examiner they are hearing the tone for the same time, that means the patient has normal bone conduction. That means the hearing is normal. In case of conductive hearing loss, we cannot have any finding over here. There is no role of this test at all in finding the conductive hearing loss because we are already blocking the air conduction in over here. Now, if you can check it yourself, like if you are playing something, if there's some sound coming, if you press the tragus inwards and if you take it outwards, you'll see the difference that will happen when you do that. So, from that, we can tell in case of conductive hearing loss, there is basically a blockage in the pathway. And in this test, we are already simulating that blockage by pressing the tragus inwards. And because the patient has a normal cochlea over here, that absolute bone conduction test will also be normal. So, there is no role in testing for conductive hearing loss over here. In case of short sensory neural hearing loss, we'll see a shortened duration where the bone conduction sound will be perceived for a shorter duration in the patient, and the examiner is able to hear it for longer, and this will happen if there is any damage to the cochlea or the auditory nerve. So, this is about the absolute bone conduction test. The difference between absolute bone conduction test and the Schwabach test is that in Schwabach, a part of air conduction is also getting tested. There's some sound coming via the air conduction route as well, along with the bone conduction. Whereas in absolute bone conduction test, we are only testing for bone conduction by occluding the external auditory canal by pressing the tragus inwards. So, this is about these tests. Now, these are the four most important tests. Let's try to first recapitulate what are the findings that we found. So, for Rinne's test, in a normal case, the air conduction is more than bone conduction. So, we'll get a positive Rinne in a normal person. In a conductive hearing loss case, we'll be seeing a Rinne negative, which means the bone conduction will be more than air conduction. And in sensory neural hearing loss, the result will be same as a normal case where we see a Rinne positive. Next is Weber's test, which will be equal in normal, lateralized to the affected ear in case of conductive hearing loss, and lateralized to the better ear in case of sensory neural hearing loss. Next is absolute bone conduction test, where it will be same as examiners in both normal as well as conductive hearing loss as we just discussed, and it will be reduced in case of sensory neural hearing loss. And lastly is Schwabach's test, which will be the same as examiners in a normal case, and it will be lengthened in conductive hearing loss and reduced in sensory neural hearing loss. So, out of absolute bone conduction Schwabach's test, can you tell me which is a more sensitive test to perform? As I'd mentioned, the we are testing in Schwabach test, air conduction also plays a role other than bone conduction, whereas in absolute bone conduction we are only testing bone conduction. We have removed the component of air conduction. Therefore, ABC test will be a more sensitive test amongst these both. Now, amongst Rinne and Weber, if what is the more sensitive test over here? Here, Weber's will be a more sensitive test because Weber's can actually detect a hearing loss as low as 5 decibel. But to detect Rinne, we need at least 15 to 20 decibel of hearing loss to detect. So, in terms of sensitivity, Weber's test will be a more sensitive test amongst all of these, and in between ABC and Schwabach test, we'll prefer the ABC test. Lastly, we have two more tests to discuss. First is the Bing's test. Now, Bing's test is a test which we are using to test the bone conduction. And what we do here is we'll do this ear canal occlusion and we'll test the effect of this ear canal occlusion on hearing. So, how do we perform this? We'll take a vibrating tuning fork and we'll place it on the patient's mastoid process. And then, alternatively, we'll open and close the external auditory canal by pressing the tragus inwards and outwards. What would be our interpretation here? In case of normal person and a sensory neural hearing loss, the patient will be able to hear louder when the canal is occluded and softer when the canal is open. You can try this out yourself in your own ear. When you press the tragus inwards, you will see that you are able to hear louder than when you open it. That's because when you press the tragus inward, the air conduction component completely is removed. So the bone conduction feels louder. This is known as Bing's positive. Next is conductive hearing loss, where in case of conductive hearing loss, this change in loudness that we are able to appreciate normally, the patient will not be able to appreciate any change in loudness. And this is Bing's negative. Why is this happening? Because in a conductive hearing loss, let's say this is the ear, this is the tympanic membrane, this is the middle ear, and this is the cochlea. So, in a conductive hearing loss, we already have some kind of blockage over here. So, when you're pressing the tragus inwards, there is no real effect that it is doing. The air conduction that we are meaning to block when we are doing this, pressing the tragus inwards, is already there. So, therefore, there will be no appreciable change in loudness for this patient. It will not enhance their bone conduction. So, this is about Bing's test. And last of all, we have the Gelle's test. Gelle's test is very similar to Bing's test. The only difference is how we do it. So, in Gelle's test is also a test of bone conduction, but here what we are doing is we'll also test the effect of increased air pressure in the ear canal on hearing. The method is almost the same. We'll place the vibrating tuning fork in the on the patient's mastoid, and then we'll change the air pressure in the ear canal. Here we'll do this by using the Siegel's speculum. Now, what is the interpretation over here? In case of a normal person or a sensory neural hearing loss case, we'll see that the sound becomes softer with air pressure. What is the pathway over here? So, when you're increasing the air pressure by Siegel's speculum, this air is going and pushing the tympanic membrane and the ossicle inwards. This will further increase the intralabyrinthine pressure, which will lead to immobilization of the basilar membrane, and therefore there will be a reduction in the hearing. This is why, in case of sensory neural hearing loss and normal cases, the sound will be softer, as you introduce air pressure. This is known as positive Gelle's test. Negative Gelle's test is seen in conductive hearing loss, where no change in loudness will be appreciated. Why is this seen? If you look at the mechanism over here, the mechanism involves where pushing the tympanic membrane and ossicle inwards. Now, say in a conductive hearing loss, especially in cases of otosclerosis, when there is stapes fixation, this pathway stops right over here. If this pathway is not able to go forward, you're not going to be able to change the appreciate in loudness. Therefore, conductive hearing loss will be negative Gelle, and you will be seeing no change of loudness over here. Now, this is very, very important. This was important earlier as a test because this was a test that we would do to detect otosclerosis. But nowadays, this test has been replaced by tympanometry now, which is a more sensitive test. So, this is all about the different tuning fork tests that you need to know. I hope you have understood this, and I'll see you in my next class. Thank you.